Able to see my screen here?
Yes, we can, thanks.
Okay. For some reason, my video is not working. At least I don't think you can see me. I don't mind being seen. It's not really worth it for you guys, but if you can see me, great. But I'll just go ahead and start because I apologize if anybody's been having to wait. So we're talking about ossicular reconstruction this morning. Thanks for having me involved. I'm Chuck Yates. I'm at Indiana University School of Medicine, and I'm a neurotologist. So I don't have any disclosures, and I'm not going to be discussing any non-FDA approved devices or anything like that, or really any off-label usage of any FDA approved medicine. So I want to start it out with a kind of clinical scenario that helps reflect on where we make these decisions when we go about seeing these patients and going to the OR. So this is a child that comes in his office, into your office with his mom. He's 12. He's had a surgery by you before for in his left ear and had a cholesteatoma there. He's not having any pain or infections. The problem was really 6 years ago when he had a 2-stage surgery, and hearing was good for several years, but then suddenly it's gone out. There isn't any other problem, no tinnitus, imbalance, vertigo. So on physical exam, you know, the right side's normal, the left has some post-operative changes associated with it. The TM's a little bit retracted and hypermobile. You can see that there's a square piece of cartilage in the posterior superior quadrant without any type of effusion, and using 512 hertz and as well as a 256 and 1024 tuning fork. The Weber test lateralizes to the left, and the Rena test is negative on the left, positive on the right. So here's the audiogram. You see this young man in the left ear has a severe conductive hearing loss. Right side is totally normal, and you can see with masked bone that the problem is his left ear do have a little notch here, similar to a Carhart's notch. Get a CT scan, high-res CT, to have a look. And so here in your axial sections, zoomed in, you can see pretty clearly in the left ear that there's a prosthesis in here, and that doesn't really look to be in an optimum location. So, you know, you can assume that this prosthesis has moved, and so now you're going to have a discussion about what you're going to do. You've got a number of options. So when you do ossicular reconstruction, you are recapitulating basically the structure of the ossicles. The ossicles themselves of the middle ear are one of the things that define mammals as a whole. And everybody knows the anatomy of these, but it's some pertinent points here to think about when you think about the connection of the anatomy and physiology. The stapes is pretty small. You can see that the malleus and incus are 25 and 27 milligrams respectively. You can look into the anatomy from inside the ear, so you can see on the back wall of the middle ear space where the inner ear is, where you see your stapes and oval window. You can see the facial nerve right above it. You can see the branch of the facial nerve, the chorda tympani, coming through here, that is always part of any middle ear type of operation. It's something that you know, may want to be avoided depending on its location, to avoid any postoperative dysgeusia or agnosia on that side. The portions of the ossicular chain that come from different areas developmentally are something that you are frequently tested on. However, the reality is that the easiest way to think about it is not really by its location within the bone itself, but by its location in the ear. So the first arch remnants are, the things derived from the first are from in the epitympanum, and the second are in the mesotympanum here. And then the base, or the stapes foot plate, really comes from the odic capsule in its origin. And it is important for a number of causes of the ossicular discontinuities to kind of focus on what the blood flow to the ossicular chain is. So the anterior tympanic artery here comes out of the petrotympanic fissure. This anterior tympanic artery is a branch off of the internal maxillary artery. You can see that as it comes out, you develop an ossicular branch. This branch actually comes out and goes down the lenticular process. So this distal portion of the lenticular process is a watershed zone, and this is why a part of the reason that the incus is going to be the most commonly involved ossicle and acquired pathology. You can see in high resolution here that you have these nutritive foramina where the blood vessels go into the bone itself, but not all of the blood flow is from the arteries itself. As you can see on a high resolution image, you can see mucosal contributions as well. So it is certainly part of the story, but not the entirety of the story. So the role of the ossicular chain is to help with impedance matching. Impedance matching is essentially the process by where you have sound traveling through the medium of air transferred to a fluid medium. And so the movement within the air is a lot significantly easier compared to within the fluid itself. So you have three different principles that help increase this amplification. One is the catenary level, where basically there's 2 times the amplification of sound at the umbo than other locations. So basically the movement of the tympanic membrane somewhat gets focused at the umbo itself. There's also the ossicular level, that's the malleus long arm. It's 1.3 times longer than the incus process, so that increases about 1.3 times, or a 2.5 decibel increase. The biggest contribution is not the ossicular chain directly, though. It's the hydraulic lever, and that's basically the 17 to 1 increase, although I have read studies that have set up as high as 20 to 1 difference in area between the area of the tympanic membrane and the oval window, which essentially focuses all of that vibratory motion onto the oval window itself. So this actually means that the middle ear gain is frequency dependent. And so that means that you have 20 decibel gain for lower frequencies, and then up to 25 decibels for around 1,000 hertz. But then this gain decreases a little bit at the higher frequencies. But overall, this is about a 44.2 times increase. Now, this comes into what our outcomes are. To a degree. So we know that because the malleus plays a critical role in all these 3 levels for impedance matching, that if the malleus is present with a port or a torp, you tend to get a better outcome. Its use predicts better outcomes. Now, this is independent of a lot of other factors. I mean, it doesn't matter if you have a malleus, if you have a great big hole in the tympanic membrane, or if your foot plate doesn't move. I mean, so all of these come together to give you a big picture. But still the malleus is important, because when the malleus is there, otherwise you can just connect the tympanic membrane through the malleus to the oval window, and at least anticipate a better outcome than you had before. So the kinds of problems you can treat are problems with the ossicular chain itself. So those are really related to some type of ossicular fixation, so lack of movement of the chain, or a ossicular discontinuity. And then the causes themselves. The most common cause overall is cholesteatoma. So that's going to be 80%. The sequela of chronic otitis media would be, if paying attention to math, about 20%. However, some studies have said that it can be a little bit higher. So this is related to infection. This is the infection causes, and so separate from the rate of overall causes. Tympanosclerosis, so scarring of the ossicular chain, can certainly cause it. Otosclerosis, both at the fistula and a fenestrum, which is a focus of otosclerosis that then goes straight on to the oval window or on the round window, are worthy of their own lecture, and we don't want to not mention those for this lecture, but they're not really going to be the focus of the ossicular reconstruction that we'll talk about. And then trauma and other congenital types of problems with the ossicular chain. So here's a picture of an IS dislocation where there's fibrosis, and this is after a horse kick to the head. Here's a dislocation separating the malleus and the incus. So sometimes you can see this preoperatively, sometimes you can actually see the cause when you're in the OR. So in your patient that you're seeing in the clinic, with the rest of the otologic exam, obviously otoscopy and otoscopy with a microscope being the best, and pneumatic otoscopy are the portions of your exam that can be helpful. In addition to your other physical findings would be use of the tuning forks. Using 256, 512, and 1024 tuning forks can give you a good picture of what the conductive versus sensory neural hearing of those ears. We have frequently audiologists with us, so we can do tympanometry and then audiometry. Now, interestingly, some of the findings that you would be able to see with a complete ossicular chain discontinuity, an intact tympanic membrane would then have the max conductive hearing loss about 55 to 60, even as high as 70 decibel difference. Now, if you have a complete ossicular chain discontinuity, but you have a perforation, you've then removed a barrier to acoustic coupling. So if you have a perforation in place, you have a slight improvement of the hearing in the instance of having an ossicular chain discontinuity, where you may have a 10 to 15 decibel difference. Audiometry, normal is type A. You can see with ossicular chain issues either a fixation, so the shallow, the type AS, or the detached A type D, which is a hypermobile ossicular chain being shown up on impedance tympanometry. So imaging is not essential for ossicular reconstruction. However, many people use it. It can give preoperative prognostication in some areas. Generally, in my practice, unless I have a reason to think there's something that I can fix, I'm not necessarily telling people that they should necessarily do a surgery unless we have a good plan in place, and that you're maximizing benefit over risk. So you want a thin cut, non-contrasted CT of the temporal bone. Obviously, you can see extensive cholesteatoma. Here's an example of a cholesteatoma. Now, this is something you should be able to pick up in the clinic if you have this level of soft tissue here and accessible through the external auditory canal and erosion of the scutum itself. But you may also have be able to see a dislocation. Here's an example of seeing ossification on the anterior malleolar ligament. You can see other inner ear causes of conductive hearing loss, and that can be very helpful preoperatively so that you don't do an operation that you know is not going to work. A third window, an enlarged vestibular aqueduct, some other congenital anomalies can be involved with causing a conductive hearing loss, and so you would want to pick those up. So when do you operate? So one of the things, because this is an elective operation being part of the reason that I'm giving this lecture this morning rather than operating, is because we're on hold due to the COVID. But the status of the uninvolved ear. So an operation in an only hearing ear in some cases may contraindicate surgery because one of the risks of an operation is further loss of hearing, and that might be a situation to consider hearing aid. But it is a relative contraindications, and there may be a time when you would consider that to be appropriate. Another situation is if you have bilateral disease, generally you want to work on the worst hearing ear first. At the time of surgery, I would consider an active infection, especially a suppurative middle ear infection, to be a contraindication and a reason to reschedule surgery. Relative contraindications might be if there's a primary cholesteatoma surgery. A lot of people, including myself, prefer to stage ossicular reconstructions. Persistent eustachian tube dysfunction, such as we see here with this very atelectatic situation in the middle ear. This is an operation that is going to help the ossicular chain, but it doesn't necessarily help the long-term eustachian tube function. And so that problem is not going to go away. And then sometimes the tympanic membrane perforation, especially if you think that it may be an operation where you open through the oval window, you wouldn't want to do that at the same time that you repair a perforation. Repeated failures, especially with the same prosthesis, would be another contraindication. So there are other hearing options other than ossicular chain reconstruction. So you can do a conventional hearing aid. That can be a very reasonable way of taking care of a conductive hearing loss. The osseointegrated implants or the bone anchored hearing aids, common brands are Baha and Ponto. Ossia and some other things are released recently, and new things are on the horizon with these. And then some of the implantable hearing devices, such as a floating mass transducer, which is the Med-El sound bridge, or piezoelectric transducers, such as the Esteem device. And this is showing an example of one of these floating mass transducers here on attached to the incus itself. But this floating mass transducer can also be put in the round window. So the goal of this surgery is to recapitulate your middle ear impedance transformer and maximize gain. And so based on a preoperative audiogram, you want to give a patient a potential to regain serviceable hearing within that ear. And so you can have this then based on the underlying etiology, what you're going to do with the operation. So conductive hearing loss with an intact drum, would just be a ossicular reconstruction. Conductive hearing loss with the draining ear might be a different type of operation, including tympanomastoidectomy. And same conductive hearing loss with a dry perf may just be as simple as closing the perforation. And then mixed hearing losses may require, even with the best outcome, a hearing aid afterwards, and that's an important discussion to have. the goal of operation is to have a safe, dry ear and then to improve hearing, but always a risk on the table is that hearing can be worse with an operation. So materials and techniques for this have evolved considerably. Since the beginning of development for it, the goal has been to provide an ideal ossicular prosthesis, one that's biocompatible and lightweight. It's easy to use for the surgeon, so that means it's easy to trim, to handle, to place, to adjust. And then it's going to have good sound transmission qualities, and you want it to be MRI compatible with other technologies that a patient may need for other locations in the body, and then have it be stable in the middle ear for many years. So here's a kind of a table form showing a lot of the evolution of materials and technique. Really, some of the first things done were the use of an autologous incus, so an autograft, where frequently if you have loss of the long arm of the incus, you still have a body, and that can be sculpted into a prosthesis that can join the malleus to the oval window or to the stapes itself. Various other grafts have been tried, including homografts, so donated from other people. My hospital used to keep a bone bank, so just a bunch of incuses that were taken out and left in formalin, and things like that have gone out of favor due to the concern for prion disease or other disease transmission. And the dominant things currently on the market have been titanium, because of its it's essentially lightweight, strong, biocompatible. Hydroxyapatite is also biocompatible, and then combinations of these. Now, there are more types of ossicular reconstructions than or prostheses than we could really name in this entire lecture. And the important thing when you look at all outcomes is to really find one that you're comfortable working with. I'm not really going to advocate for a particular type, and in the modern world, we still get just as good of post-operative hearing outcomes with autologous incus as we do with some of the manufactured prostheses. So it's what you're comfortable with and what the patient has. For consideration of the surgery itself, you're going to do this with some kind of anesthesia that can be strict local anesthesia, or it can be monitored anesthesia care with sedation, or a general anesthetic. And this can involve choices made with the patients about their preference, whether or not you're in a training situation, the patient comfort, time of procedure, etc. You want hemostasis in addition to your local anesthesia. So usually I just use 1% lidocaine with 1 to 100,000 epinephrine. Many otolaryngologists use custom concentrations or epi alone, avoiding lidocaine so that it doesn't get onto the facial nerve and cause a brief postoperative weakness. And higher concentrations of epi can sometimes be used to provide better hemostasis. Generally injected inside the meatus at the junction of the hair-bearing area. The hair stops at the cartilaginous portion of the canal, and the junction of the cartilaginous and bony canal is a good place to inject in 4 quadrants. So the surgical approach can vary as well. A lot of times, probably most commonly, it's a transcanal approach, but if there's a narrow canal, a post-auricular approach, maybe with concomitant canalplasty, or an endoral approach are fantastic approaches for this. Sometimes with a second look, maybe in a previous canal wall up mastoid, a transfacial recess approach can be used. I have done this approach as well, and in appropriate situations, it can be excellent because you don't have to lift up the tympanic membrane, so the actual height of your prosthesis is not something that you're guessing at all. So the approach and exposure, use a tympanomeatal flap approach. So make an incision, make it a little bit thicker if you may have to curette the scutum at all. Elevate, and as you elevate, you're going to elevate for exposure versus tension. I tend to go make my incision up to 12 o'clock and a 6 o'clock. I don't bring any a second incision down to the annulus, because if I want to continue going forward, I would just go forward using a middle ear type of scissor here, but this provides great visualization. You want to be able to see, you know, the incus and the stapes. Most of the time, this is more of what you see when you do a stapes, because usually that's, you know, you don't see an intact ossicular chain there for ossicular reconstruction. Considerations in previously operated ears, such as canal wall down, maybe an altered canal incision where you're going to avoid going across the vertical segment of the facial nerve because it may not be bone covered, and that's not a good place to put any type of blade. So during your middle ear exploration, you may see disease factors, residual cholesteatoma, which can be treated at the time, serous fluid, dehiscent facial nerve. You must check the rest of the ossicular chain. Even if the incus is absent, you want to make sure that the malleus is mobile. Palpate every portion of the ossicular chain that's present. Palpate your stapes if present. Palpate the stapes foot plate. Assure that you have a round window reflex, because if you don't, you may have other locations that need to be addressed to get an optimum surgical outcome. And then, are you able to have a good vector between the malleus and the stapes? Stapes capitulum itself, or if it's absent in the foot plate, and so that can a catenary lever be replicated? So prosthesis selection is really dependent on surgeon preference and clinical scenario. Obviously, no matter what surgeon preference is, there are clinical scenarios that are going to dictate one type of device or another. So here's a table just kind of describing the different reconstructive options that are based on the status of ossicles. In all of these, the incus superstructure is absent, and then whether or not the stapes is present, and whether you're using a TORP then in cases where the stapes is absent, that's in a total ossicular reconstruction prosthesis, or then in cases where the stapes is present, that would be a partial ossicular reconstruction prosthesis or a TORP. So here is a number of examples of this Austin A class where you have a stapes in place and a malleus, but some type of deficiency of the incus itself. Most frequently, that's a portion of the long process that's been destroyed. Again, most frequently by cholesteatoma, because of the pathway of cholesteatoma development and because of the blood flow to that area. So this is showing an autograft here, an incus interposition, where you may shave down the long process and create a little well for the capitulum and a portion for the malleus. One thing is that this does take time. It can take longer than it does to have a manufactured prosthesis, and then in some cases that's why it's fallen out of favor. But doing it well, you still get a great result. as you place this in, you want to lift the prosthesis and the malleus together and then gently seat those on the stapes capitulum. Sometimes, especially in areas of retraction, you want to cut the tensor tympani tendon here that can be found anteriorly coming off of the cochleaform process, especially if the tip of the malleus handle is too close to the promontory or if you're not able to manipulate that area well. So here is some example of some allografts, alloplastic porps, many types being available. This is showing your facial nerve and your stapes. This is your target, the stapes capitulum at the stapes superstructure. So this little basket on this type of prosthesis will just fit under there, and maybe a hook go under the malleus. Some of these are windowed and just an edge go under the malleus itself, or sometimes all the way up to the tympanic membrane. So directly. So the tips with this is you grab with a suction tip and place and then center it on the stapes, and then be meticulous about its appropriate length and angle. You don't want too much tension or too little tension. Millimeters do truly matter here, and that's the difference between a good and bad outcome. So the cartilage interposition is frequently used as an interface between a prosthesis, and this decreases likelihood of extrusion. And so here's a image where you have a titanium graft covered by kind of just a dried mucus, but basically it's extruded through the tympanic membrane. So if you have a thicker portion of mesenchyme there, you can cover your prosthesis and make it less likely over the long term to extrude. Good locations are the tragus or the contral bowl. Those are available readily within your surgical field. It can be thinned. 0.2 millimeters is or 0.2 is an optimum thickness, and so you want it to. It can be done with a scalpel, but that can lead to some injuries. So there are different devices by some of the ossicular prosthesis companies that can be used. So when placing it, you want to tilt the prosthesis posteriorly and inferiorly, place cartilage over the anterior edge of the platform, and then kind of rock it back into position. Now it's key here to avoid much downward pressure, because then you, with pressure directly downwards, you can sublux the stapes superstructure and foot plate into the vestibule, causing hearing loss and dizziness and general dissatisfaction by all. So if there is a very minor erosion of the incus itself, or simply a disarticulation, there are even more options. It depends on the size of the gap between the stapes, between the incus and the stapes. So a small 1 to 2 millimeter area can use like an isomeric bone, or sorry, an ionomeric bone cement to restore continuity. And when you do that, you want to place packing over the foot plate so that you don't get the bone cement on the foot plate itself. But then you can wedge cartilage into that space, or use this Plester angular clip, which goes onto the incus and caps onto the stapes itself, or a type of helix, or an Applebaum prosthesis. Or you can take out the incus and use a porp. So lots of options here. So if you have an absent stapes superstructure, so this is Austin class B and D, you're going to use a total ossicular reconstruction prosthesis, or a TORP. And so that means that your foot plate or the oval window itself is going to the malleus or the TM. One of the challenges with outcomes with this is it's a little bit easier for the prosthesis or to dislocate from the foot plate or to slip. So a host of different options, including cartilage plates or spikes, in the end of it, or a shoe over the foot plate. Here's a separate shoe. Here's a shoe attached that can go down in the oval window, so be less prone to any type of movement with life from that point on, certainly during the healing process. But you know, if people are having doing scuba diving or having big changes in pressure in their ears, including sneezing, nose blowing, those can be a factor. So if there's no foot plate, you must place a graft over the oval window, and you want to minimize downward pressure, and it's preferable to have something actually anchored to the malleus so that it can't push down into the vestibule. So with the key kind of to ossicular reconstruction is the prosthesis placement. And one of those main keys is getting the appropriate length. So if you're going to use cartilage with it, you may have some ways to size before with dummies and put them in, but you have to consider the length of your cartilage when you're done. A partial ossicular reconstruction prosthesis is going to be about 2 to 2.5 millimeters from the plane of the capitulum to the neck of the malleus. If it's too long, you know, that can cause angular ligament tightening and it risks entering the vestibule, and it can lead to a poor outcome as well. So tension can be decided by the anatomic location of your tympanomeatal flap. So this is one of the rationales for staging these after an initial tympanomastoid, is you know where the tympanic membrane, its kind of natural height is, and you aren't trying to guess where it's going to be over the long term. If you have too little tension, you're a little more likely to have displacement, like our case seen here, and then you want to make sure you're accurately sizing the prosthesis. This is showing the sizing of one brand of prosthesis, and then you clip the top, and you can still manipulate the length a little bit even after doing that. So the other thing is then, ideally, if you have a malleus in place, is getting this proper angle with the contact with the malleus. Sometimes if that risk gives you a risk of tipping over, it's better just to put it on the tympanic membrane. But a 30-degree interface with the neck of malleus is what would be recommended or optimum when it can be achieved. If it's greater than 45 degree, then your annular ligament is placed under tension. That's not going to be a good long-term outcome because sound energy is going to be converted into an inefficient rocking motion rather than just moving the foot plate appropriately. So the expected outcomes then are successful hearing results. Would be, you know, an excellent one would be less than 10 dBs, 10 decibels. Good would be between 11 and 20, and fair is 21 to 30. So the strongest influence on the success then is a mobile stapes structure, and the presence or absence of a malleus, and then eustachian tube dysfunction is an indicator of long-term success. So here's a series of you know, fairly significantly powered studies that are mostly retrospective, but look at a large number of people, and generally they're, even with improvements in technology for the prostheses and otherwise, TORPs have generally better outcomes than the TORPs, and this is really because you have a secure medial anchor with a TORP that's more difficult with a TORP. Slippage does happen, and a TORP also may represent a more severe underlying disease. So complications can occur. Intraoperative complications could be subluxation of prosthesis or the stapes foot plate into the vestibule. Here's an example of that on CT. That, you know, can cause sensorineural hearing loss and vertigo. Generally, if you realize that's been done at the time, you want to get that prosthesis out of the vestibule. Delayed problems can be extrusion. That's more common with a direct prosthesis placement on the tympanic membrane itself. It's less common with cartilage interposition or the use of the malleus itself. And rates have been all over the place in various retrospective studies between 5 and 39%. It's 1% for titanium with cartilage and about 3.3% for hydroxyapatite. So some people, including myself, use hydroxyapatite with cartilage. Incus erosion is a potential problem long-term, or movement of the prosthesis itself. Here are kind of bigger studies, Jung and others in 2006, looking at the failures, which were airborne gaps greater than 20 decibels. And the majority of these were due to continued or progressive middle ear disease. The surgeon, well, was attributed to surgeon technical error or a problem with the prosthesis itself was pretty small number, only 36 of those 242 patients. So erroneous diagnosis of vesiculoplasty, then that mixed malleuses, fractured stapes superstructures, or IS disarticulations, or alternative causes of conductive hearing loss. Here's a study of 140 patients with titanium prostheses, showing pretty good success with an airborne bone gap within 20, and then the malleus handle and mucosal status, middle ear most predictive. The OOPS index, the vesiculoplasty outcome parameter staging by Dornhofer and Gardner, is a scheme that actually incorporated multivariate analysis of 200 ossicular reconstruction. And again, significant prognostic factors for malleus status, drainage, fibrosis of the middle ear, and non-significant status in this study was the presence of the stapes superstructure or the preoperative airborne gap. So here is our young man after getting a different kind of prosthesis that clipped onto his stapes that would assure that it wouldn't slip off again. And this was about 3 years ago. He's maintained a good result since having a revision ossiculoplasty. So here are some references. I'll provide these slides for you, and appreciate your time. Appreciate University of Kentucky team for putting all this together. And a lot of these slides were written by a former resident of mine who's on faculty at Medical College of Wisconsin, Mike Harris, and certainly he deserves credit for his work as well. So thank you, everybody. I appreciate it. I'm sorry for the problems with joining.
Thanks, Chuck, and apologize for the confusion at the front end. That was a great lecture and very apropos. Really appreciate it.
No problem, Brett, and thanks for putting this together, and thanks for having me a part of it.
Yep, will do. And I've been talking to all your colleagues today, trying to get your contact to tell you what was going on. So anyway, we'll take a very short break here, and then we will get going with our next round of lectures coming up. To pull up the schedule here.
Oh, sorry, I had my IU stuff on the background the whole time. I didn't mean to do that.
That's okay. So, all right, we got coming up next. Have another friend of mine, John Schneider from WashU, is going to be talking about communication. Dr. Schneider is a rhinologist at WashU, and so look forward to hearing him talk here in about 5 minutes. So thanks again, Chuck. Really appreciate it.